But essentially, it's just to go over mechanisms. How do these new therapies work? To describe what these therapies have done to the outcomes of melanoma. And then to talk briefly about where things are going. And also, just because there's some pretty relevant and new new FDA approvals in the adjuvant space, we'll just briefly talk about those as well. If you walk away from this talk with anything, this is all you need to walk away with. It's that simple. I literally got a call last week from a cardiologist of a patient of mine who was asking, he essentially said, well, this guy, he's got metastatic melanoma, and so, it's not great, so I'm not going to change his defibrillator battery. This was a patient of mine who is about a month away from completing a 2-year course of Pembrolizumab. He started out with metastatic disease in his lung, metastatic melanoma in the lung, and had a complete response for about a year plus. And this is the kind of call I get, So this is, I think most of the crowd here, probably all of you, really understand that there's a lot of major changes going on, but it's really important to spread the word in the medical community because it just hasn't gone out yet. 2011 is the beginning of all of this. It wasn't that long ago. Let's go back to 2009, and Dr. Koh kind of went through this already. At that time, if we focus on metastatic melanoma, the overall 5-year survival was about 12%. Median overall survival was pretty short, 6 to 7 months, barely half a year. And so highlighting this 12% because we will reference them in the next few slides. So, we tried chemotherapy for decades. Didn't do much good, and actually if you compare this survival curve with dacarbazine versus temozolomide, there's no difference between the drugs, and actually the overall 5-year survival is less than the 12% that you see. So makes you wonder a little bit about the usefulness of chemotherapy here. So then we had IL-2, high-dose IL-2, which we could only use in the very, very fit with very small tumor burden, so a very small number of patients, and we've moved the needle to 15%, at best a 5% improvement, and in only a very small set of people. So then we started seeing very different things. So this is just an example. There's too much data to show everything, but this is 5-year survival with single-agent nivolumab that was presented 2 years ago. The 5-year overall survival is 34%, so almost triple what we've seen in the past. So first of all, there are 2 different categories, and we need to talk about them separately. One is immunotherapy, the second is targeted therapy. Multiple speakers have sort of alluded to the 2 categories, but they work very differently, and their mechanisms really have a lot to do with how they their differences in response rates and the differences in the durability of their responses. So when you think about immunotherapy, immunotherapy is turning off the off switch, at least for now, okay? There will be other immunotherapies coming that will work slightly differently, but this is how you need to think about all the current immunotherapies, anti-PD-1 and anti-CTLA-4. So this is kind of that schematic, right? So the whole idea is that tumors, especially, well, in particular melanomas, are able to bind to T cells and make them inactive, right? And so what these drugs are trying to do is break apart that interaction and revive T cells, allow T cells to do the cytotoxic oncolytic effects that they can do naturally. So let's take CTLA-4, the first drug that was approved in 2011. This is just to show normal T cell activation, right? The T cell interacts with the antigen-presenting cell. So here, T cell, antigen-presenting cell. The 2 of them bind, have interactions, and then you stimulate the immune system, right? So the issue here is, so with CTLA-4, what happens is you can you can actually, when the CTLA-4 receptor binds, then there's a blockage. So this is sort of the body's natural mechanism of turning off the immune system. You don't want it on all of the time, or we'd be walking autoimmune diseases, right? So this is the body's natural way of sort of, every switch has to have an on and off, and here's your on and here's your off, right? So when we talk about ipilimumab, or an anti-CTLA-4, that's an antibody that binds this inhibitory receptor, the CTLA-4 receptor, takes away that interaction and returns the T cell from inhibited to stimulated, so that the T cell can then go find tumor. All right. And so similarly, PD-L1 antibody has a similar mechanism. However, the interaction here is not between the T cell and the antigen presenting cell, but between the T cell and the tumor cell. So this is thought to be a little bit more tumor specific, where anti-CTLA-4 kind of just diffusely turns on the immune system. The anti-PD-L1 is supposed to direct the inhibition that's caused specifically by the tumor cell. So you can see the tumor cell itself has a way to bind T cells, and then when you add anti-PD-L1, then you take away that inhibition of the T cell, and then it can cause tumor cell death. So here are anti-PD-1s, nivolumab and pembrolizumab, and actually a few more that have been discussed in other talks. So now switching to targeted therapy. So targeted therapy is turning off the on switch, all right? There's a switch that's been, we'll go through the pictures. So first we start with the scientific version, right? So we saw this in Dr. Koh's talk. In general, BRAF is a signal for cell proliferation and survival, and that's normal. We want cells to proliferate and survive. The problem is when a tumor gets a mutated BRAF, there is constitutive activation. So the on switch is always on. You can't turn it on and off anymore. It is always on, and that causes too much proliferation and too much cell survival, which are the hallmarks of cancer. So if you think about it, it's, lights that can go on and off. This is the normal state of things. And with mutated BRAF, it's the overdone neighbor who doesn't ever take down their Christmas tree lights, right? So what we do with BRAF MEK inhibition is to essentially tape that switch down. That switch is now, that had always been sort of taped up, is now taped down with these drugs. And the reason why we do both combination BRAF MEK inhibition is we found the combination does better than single, because if you saw sort of the complete graph, there are ways to get around the BRAF and still activate at the MEK level. So if you if you block at both levels, you get better tumor killing. So let's see what these drugs actually do. So we'll start out with the metastatic melanoma setting, okay? So I only put up this slide. It's a gratuitous New England Journal slide because before 2011, melanoma was never in New England Journal. And pretty much almost every single one of these papers that I'm about to show you is in New England Journal. It's quite amazing, the difference. So this data I'm going to use to sort of show the effect of CTLA-4 alone, PD-1 alone, and the combination, all right? So this is our most recent data published last year. It's the Checkmate 067 study. What it compared was CTLA-4 alone, ipilimumab, PD-1 alone, nivolumab, and the combination of PD-1 CTLA-4 inhibition, so nivolumab, ipilimumab, okay? This has some of our most mature data at 3 years. And if you look at the 3-year survival, so now you remember all the way back to the original slide, our 5-year survival was 12%, okay? So now at 3 years, the combination of CTLA-4 and PD-1 has an overall survival of 58%. This is just radical for melanoma. PD-1 by itself is pretty darn good too, 52%. All right, so there's not that much of a difference between the two of these, and it's well over 50% survival if you're talking about any one of these. Now, ipilimumab, the drug that was sort of the first of this generation approved in 2011, still also has a 3-year survival of 34%, and we've seen with some of the prior studies that this curve pretty much plateaus at this point, and these are long-term survivors. So we hope the same will be true for PD-1 and CTLA-4 plus PD-1. All right, so just to see a little bit more powerfully what this does, what these can do, you can see the complete response for combination immunotherapy is 19%. So you're talking about a metastatic melanoma patient that you look in the eye, they are worried that they are not going to see their grandchildren being born next year, and 1 in 5 are going to have a complete response. That's very powerful. Even with anti-PD-1 alone, 16%. It's pretty good. The other thing to point out is that the other categories, so there's 40% partial response, 12% stable disease. So if we take that disease control rate that Dr. Adelstein was discussing earlier, that is 3/4 of the patient, or 3/4 of these patients will have disease control, which is remarkable because melanoma, as we've all seen, grows. There's no melanoma, there's the rare natural history strange melanoma that doesn't grow very quickly, but for the most part, it grows and grows. So to even sort of stun it is an achievement. The other thing that is sort of remarkable, and again, Dr. Adelstein alluded to this when he was discussing the anti-PD-1 for the cutaneous squamous cells, is how long these responses are sustained. What's the durability? And if you look at the combination, and this is 3-year with 3-year follow-up, the median duration of response has not been reached. We don't have a number for it. If you look at the median duration of response for anti-PD-1, so the bottom end of the range, of the confidence interval has been reached at 36 months, but we don't have a median, and we don't know what the top of that confidence interval is. All right. So then comes the flip side of immunotherapy. So immunotherapy is much better tolerated than chemotherapy. There's no question. If you look at other tumor types where we've done more comparisons of immunotherapy and chemotherapy, the quality of life differences are stark. However, it doesn't mean that you're scot-free with immunotherapy. So let's highlight a few of these things. So let's just look at any treatment-related adverse event. So I'll point this out. It's not circled. Any grade of any treatment-related adverse event with combination immunotherapy is 96%. Everyone will have a side effect, pretty much. Even PD-1, which is thought to be pretty benign, 86% will have any grade of treatment-related adverse event. But granted, some of these are maybe a little fatigue or a little pruritic rash, and it's, a nuisance and not a big deal. So let's talk about the serious side effects. So serious side effects, grade 3, grade 4, the types that put you in hospitals, the type that put you on high-dose, long-term steroids. So one of the things that has to be considered when you're doing immunotherapy, and I often tell my patients this, I worry less about the side effects of the immunotherapy and more about the side effects of the long-term steroid. Because the idea is if there is going to be some kind of flare of the immune system, whether it's an immune-mediated colitis or an immune-mediated hepatitis or arthritis, you name it, our go-to is going to be steroids to suppress the immune system. I wouldn't quite call it an antidote, but it suppresses the immune system and can reverse many of these side effects. But the problem is that these steroids have to be very high dose. So, the lowest dose we'll consider is 0.5 mg per kg, but in general, we're giving 1 to 2 mg per kg of steroid over at least 6 months. The taper we've found is very important. A short taper tends to cause recurrent side effects and require higher dose steroids for much longer. So, when you give an 80-year-old individual high-dose steroids for at least 6 months, and sometimes in the case of a bad pneumonitis, you're talking about 3 months, you are taking somebody who might have started out walking, and now they have proximal muscle weakness, and they're on a walker in a wheelchair by the time they're done with their steroids, not to mention the swelling in their legs and the face and that kind of thing. So it's something to keep in mind. Now, given that the audience is mostly dermatologists here, I wanted to sort of point out the dermatologic side effects. So in general, they're mild. They're really grade 1 and 2, but you can see they affect actually a decent proportion of patients. So rash is about a third, pruritus is about a third. Most of the time, we leave these alone. You'll see vitiligo is listed as a side effect. Vitiligo has been loosely associated with response, so I'm not sure that this really counts. But and then, so here's an example. So here's a nice sampling of these are all patients that have been treated over the last 2 years, and their types of side effects. Many of these I actually don't know what they are. So if you have any ideas or they spark your curiosity, please find me afterwards. But here's and not being a dermatologist, I'm sorry, I'm going to really muff these descriptions, but you can see they're these tiny sort of blister-like things that developed all over the hands. This was within the first 3 cycles of treatment. Another random rash that we actually thought was melanoma, recurrent in transit lesions, and we biopsied, and they just turned out to be an inflammatory, some kind of inflammatory lesion. Here's the vitiligo we were talking about. This is actually a patient who was treated on with Pembrolizumab and also an injectable oncolytic virus that I will talk about a little bit later called TVEC or telemagene herpesvirus. But you can see that there's vitiligo actually at the injection sites. Another thing that's been cropping up that's a little weird is that we've had some folks who have had surgeries decades ago and suddenly have this sort of surgical scar-related rash. And then there's even some alopecia. This is pretty rare, but we see this sort of patchy alopecia that's kind of reminiscent of an alopecia areata. And then just a random rash that I have no description for. And I know because we had some discussion of, since this is sort of an autoimmune derm conference, and I know we have some rheumatologists in the crowd, that, arthralgia is an issue. It's one of the side effects I describe to patients as semi-permanent. This doesn't tend to just resolve with a high dose course of steroids, and we find that on and off we are having recurrent arthritis and are unable to wean patients off of either low-dose prednisone or have to start Plaquenil or something along that line, and appreciate our rheum colleagues for helping us out. And just pneumonitis, since that kind of many of the autoimmune derm conditions we were talking about earlier on in the conference sort of have this sort of triad of rash, arthralgias, and pneumonitis. So talking about rheum side effects, so this is a patient of mine who has swelling about a week after he gets Pembrolizumab. Happens a little bit more often with weather changes and getting wet, but it swells to this great degree. He actually doesn't walk for a couple of days, refuses to take steroids, and actually by 3 weeks later, when it's time for another Pembrolizumab treatment, he's fine. Don't know how to describe it. We haven't been treating it. But it's an interesting side effect. And then, there are definitely sort of Raynaud's-like symptoms that our patients will complain about that either get worse during treatment or are new. So let's move to targeted therapy and what targeted therapy can do. So this is, long-term follow-up. Let me go back here. Long-term follow-up of a study of dabrafenib plus trametinib, so BRAF/MEK inhibition, in comparison to BRAF alone in metastatic melanoma. And as you heard from Dr. Koh's talk, these drugs only work in BRAF mutant melanomas. And we're starting to get long-term survival, and there are a couple of interesting lessons to learn from this. So I've circled this, but let me just sort of point out. So what we do know about BRAF/MEK inhibition in melanoma is that the response rates are very high. Complete response, this is almost like ipilimumab, nivolumab. Partial response are even higher, and stable disease is even higher. So in terms of response rate, so there is here a response rate of 68%, and this is what we generally quote to our patients, but if you actually see patients on these drugs, pretty much everyone responds. And that's why I've circled this progressive disease, where only 6% have progressive disease. That's what you feel, is that when you start the drug, you're going to see shrinkage. The question is, how long will it last? So here now we're looking at the median duration of response, and unlike immunotherapy, we don't see a bunch of not reached, right? The median duration of response is about a year, and we see this. So especially when there's a very high volume disease, we've seen people progress within weeks. So there has been this thought that really there isn't long-term effect to having targeted treatment. And if you think about it, the mechanism kind of makes sense. When you sort of tape down the on switch, if there is something that's continually trying to push the on switch back on, eventually that tape will break, right? So this is kind of equivalent to sort of resistance with antibiotics or something along that line. And so you see here, though, what we're starting to understand, though, are that there are long-term responses, more than we thought. So I think initially the field really thought there weren't, eventually everybody would just become resistant, but that's not totally true. So if you look at the 3-year survival here with dabrafenib and trametinib, the combination, you're seeing a 3-year survival of 44%. So that's not the 58% that we just saw in the Checkmate trial with immunotherapy, but it's also pretty close. Let's see. And what's interesting about targeted therapy is that there actually seem to be, to some degree, markers. So both Dr. Koh and Dr. Billings were talking about markers for immunotherapy. So we talked about PD-1 and how it's not a perfect predictor. So for targeted therapy, it seems to be a matter of how much disease. So this is in the subset that had a normal LDH. So we know that folks who have very high tumor burdens have high LDHs. And for folks who have fewer than 3 organ sites and a normal LDH, there seems to be more of a separation of curves. So I'm going to move on now to talking about what's coming. So the most recent approval for not metastatic melanoma, but unresectable melanoma is a drug called TVEC or Imlygic. I'm not supposed to use names. Anyway, telimagene laherparivec. So it's an oncolytic herpesvirus. It's a modified herpesvirus that requires an injectable lesion. So anything that's sort of an in-transit MET is a good example, or a palpable lymph node is where you can inject TVEC. So it by itself as a monotherapy hasn't been all that effective. The overall response rate is in the teens. But in combination with immunotherapy, you can see this was a Cell paper that was published last year. The overall response rate, and this is a very small number of patients on a phase 1 trial, was 62%, with a complete response rate of 33%. So you're here, the response rates are paralleling what we see with ipilimumab and nivolumab, but the toxicity profile is better. What's also interesting is the response was as independent of whether this was sort of a hot or cold tumor. We talk about this a lot, that there are certain melanomas that look more hot, they have more T-cell infiltration, CD8 infiltration, this type of thing. It didn't matter whether the tumor was hot or cold, and in some ways, there's an indication that you can make a cold tumor hot by injecting the TVEC, and then thus making the immunotherapy more effective. So this again is that waterfall plot where you see these are the folks that have had responses, and these are the folks who have not. And actually, we have our own data on this. This was just a case series of patients that we could not put on the phase 3 trial that was open here. And this was also any PD-1 based immunotherapy. So in the clinical trials, it was TVEC plus Pembrolizumab. For us, sometimes it was Pembrolizumab, sometimes it was Nivolumab, sometimes it was Ipi-Nivo, just depending on clinical situation, but we ended up adding TVEC to a lot of these patients. And you can see our overall on-target response rate was 90%. So the on-target response rate of TVEC alone is, like I said, in the teens. So we had a great response rate in this group. And what was interesting was seeing distant metastatic lesions. So here you can see this pulmonary nodule completely disappearing. So again, it's interesting data. The phase 3 study is closed, and I'm sure we'll get data within the next year. But we're starting to see that you can make these combinations, different types of combinations that might move the needle even more so and potentially decrease side effects. The reason I wanted to make that future directions part very short is this. So we've known a lot about all the immunotherapy interactions for a long time, but we've never really been able to target, or we haven't really had effective targets. And so now that we do have effective targets in PD-1 and CTLA-4, you can see how many other things we could make antibodies against, and that's a lot. And then once you start making combinations, it gets to be unwieldy, for lack of a better word. There's just literally not enough money, time, or resources to do all the trials to figure out what's best. And so it's really important going forward that we have to really think about what combinations make sense. So one of the reasons I brought in the TVEC PD-1 story, partially to show our data, but partially because it's a combination that makes sense. So with the TVEC, what you're doing is it's an oncolytic agent. So you're essentially lysing cells and causing more antigen presentation. And then with the immunotherapy, then what you've got is a sort of vamped up immune system. So I describe it to patients often like, your immune system is like a detective force, right? And immunotherapy will double your detective force. You've added more cops to the beat. It makes it easier to find, but robbers can still hide. And if they're hidden very well, you're not going to get any new clues. And what TVEC does is with the oncolysis and the antigen spread, you've essentially sort of let loose a bag of clues for this vamped police force. So as we go forward thinking about what kinds of combinations make sense, I think we're going to be forced. It's just too expensive to try everything. And so it really heeds us sort of sitting down for a second, getting our very talented immunologists to put their heads together, and I won't claim to be one of them. But so that's sort of the where we're going. So very quickly, just to talk about adjuvant therapy, because there are a lot of great data that have come out within the last year. So this is another New England Journal paper. This is nivolumab in resected stage 3 and 4 melanomas. And you can see this is in comparison to adjuvant ipilimumab, there is a 35% lower risk of recurrence at 12 months. We don't have survival data yet, but you can see, this is the curves definitely separate. This is better than what we've seen with interferon, and clearly better than IPI. And so this has led to a recent FDA approval for our threes and resected fours. Also, same issue of New England Journal. There was data on adjuvant BRAF/MEK inhibition, and so this trial had been going on for much longer. We actually have survival data because it hadn't been released and had been ongoing for several years. Many people speculated that there wasn't going to be a difference, and you can see that there's a huge difference in survival curves. There's a small caveat here. This is compared to placebo. So we know it's better than placebo, but we can't prove that it's better than ipilimumab. If you look at the raw numbers, it does look like it probably is. And the other thing about this is this is all stage 3s where the nivolumab study only included 3Bs and up. So a couple of caveats, but in general, 2 effective agents. This FDA approval is expected shortly, and the impressive part of the data for the BRAF/MEK inhibition in the post-surgical setting is that there is an increase in overall survival. That's something that interferon struggled with for over multiple trials to prove an increase in overall survival. There was an increase in overall survival with high-dose IPI. However, high-dose IPI has side effects that are very tough to deal with. So this becomes very promising and becomes promising for what we're going to see with adjuvant Nivo in the future. So in summary, this will give us a little more time for questions too. So the takeaway points are simple. Since 2011, there have been 11 new drugs for metastatic melanoma, and 1 approval to become 2. 2 approvals to become 3 for adjuvant melanoma. In the metastatic setting, we have radically increased survival. In the resected stage 3-4 setting, we certainly see a decrease in recurrence and an increase in overall survival, at least for the targeted agents and most likely for immunotherapy as well. And in the future, what we would need to do is get smarter combinations that have fewer toxicities, get better at patient selection, and actually get better at managing side effects. So that's sort of where you come in as an oncologist talking in a multidisciplinary setting. I mean, we really have become much better friends with the rest of the hospital after starting immunotherapy. So you may see, your oncologist friends leaning on you more as immunotherapy becomes more widespread, not just in melanoma, but in other tumor types.